Olá, sejam bem-vindos à TV SBU na cobertura do 40º Congresso Brasileiro de Urologia aqui em Florianópolis. Eu tenho a honra de estar aqui com o Dr. Frederic Pouliot, que é professor de urologia da SBU University in Quebec e da Laval University. Thank you so much for being us here in this big conference. It's our national conference, the third biggest one in the world. So we just saw you talking about a little bit about biochemical rehabilitation, and it has been changing a lot since we have new imaging for restaging these patients. So what do you consider as biochemical recurrence nowadays with the ultra low PSA and with this new imaging for these patients?
Yes, first, thank you for the invitation. That's a wonderful meeting. I'm very happy to share with you our views from Canada. To your question, we have the same old definition in terms of PSA when we talk about biochemical recurrence. We still use a 0.2. Most of the time, I know that radiation oncologists like to treat earlier at 0.1, but as you know, many of us urologists can witness some patients that do not progress for years between 0.1 and 0.2. So I think that the two threshold are right, but personally I would use a 0.2 before undergoing other consultation requests or imaging.
Great. And for imaging, these patients for restaging, as soon as they reach 0.2, do you restage them? Here in Brazil, our big issue about restaging these patients is the access for PSMA PET. It's not reimbursed, so we have some issues about it. So how do you do? Yeah.
So basically, I think it's not a clear threshold by itself, just the PSA. So there's a definition, and then you have to classify your patient in low risk or high risk in terms of recurrence after radical prostatectomy. So if the patient is low risk, meaning that it doesn't have any ISO 4, 5, or a doubling time that is less than 1 year, then so if they are low risk, you can wait and for years, and even if the patient is elderly, never give radiation therapy. You can start with observation. If the patient is more high risk or just in between, you can really then decide what is the odds of the patient, the percentage of the patient that will respond to radiation therapy. That's how I start. Usually I do a nomogram, I calculate what is the risk or the probability that a patient will respond to radiation therapy. If the risk is or the chance to respond is very high, I'm not even asking for PSMA or whatever imaging we could request. If the patient has never been at PSA 0, if the patient has all the very high risk factor of failing localized therapy, then a PSMA PET CT would be requested. I never regressed in the situation of PSA recurrence after radical prostatectomy conventional imaging because the sensitivity is too low to really bring, and you might find false positive there, and it only complicates in my mind the clinical scenario.
Yes, for sure. And now we have most of studies based on conventional imaging, but now we restage whenever is possible with the new imaging. So how do you establish your therapeutic management in these cases?
Yes, so it's true. It complicates, and behind so you can simplify. The patient is either localized, so you don't see anything, or you have within the fossa. That's the classical patient that needs really salvage radiation therapy. Those patients will do well after salvage radiation therapy. If you find a positive lymph node, the patient is still a candidate for salvage radiation therapy, but we know that this signal, and this is not the full extent of the disease. It means that this patient is already metastatic given the specificity of the PSMA. And once we know that this patient is metastatic, the probability he will respond long-term to salvage radiation is much lower. It goes from 80% around if you have either only a sign PSMA positive in the fossa or nothing, to 20% if you have a lymph node positive lesion on PSMA. So that's something that you have to discuss with your patient. And I think that 20% to be cured, that's still significant. So most patients will say, okay, doc, let's have hormone, let's have salvage radiation therapy, and we'll give the treatment, which it will rely on our radiation oncologist to decide if there is intensification on that positive lymph node. But now it's not that simple. We have SBR, the oligometastasis that directed therapy.
Next question.
Yes. So you have the third scenario where you have either N1 and M1, or so there are some evidence that we can treat the fossa, treat the lymph node, and also treat the metastasis, and that could help with the response. But the level of evidence is not that high at this stage. But I would say that this concept really took up in clinics. I think that urologists, radiation oncologists like to tell the patient that even though if we know that this is not all the disease that we see with PSMA, they like to cytoreduce and tell the patient that they've targeted what was positive on PSMA. So this is a clinical complicated case when you have M1 on top of pelvic disease. And this is a case of tumor board at our site, at least, where we will decide if we should undergo SBRT on the metastatic lesions. And I think that most patients will get it in this case, if there are less than 5 sites.
So if there is an oligorecurrent by PSMA PET for these patients, would you consider only SBRT with no systemic therapy? In which cases would you consider, or if you consider at all?
So then comes the decision. It's not that simple, I think. Do you have localized disease? So let's say that you have this patient that had positive margin PT3, M plus in the pelvis, and M1. That patient, you can and you have a very slow doubling time. You might give the full salvage radiation plus a short course of ADT plus metastatic directed therapy. If you have the patient that had a PSA inverse 0, nothing localized as either on the PET or on pathology, and you find this metastasis, that's the question. Should we intensify? I don't think that we have clear data. Again, you have to discuss with the patient. One of the goals of metastasis-directed therapy showed by Host, this trial with choline, is to delay the time to hormonal therapy. So if we think that way and we think that maybe we can delay this ADT for 6 months, we would only give SBRT on the lesion, hoping we could delay the start of ADT. But again, it's difficult. Yes.
We have the perspective of overall survival, which is the strongest pathologic oncology outcome we have. But of course, we have perhaps young patients that will benefit from delaying ADT.
Yes.
So thank you so much for being
Thank you for inviting us.